welcome to the EMSNation podcast. We are coming to you live from Murfreesboro, Tennessee. Not to be confused with Nashville. Very close to Nashville, but nevertheless not Nashville. Murfreesboro, Tennessee. The site location of the extravagant and illustrious Fast 19 conference. We've assembled an incredible panel of folks to discuss the amazing day today. I think it was an exceptional day. Some great talks, great takeaways, learning points, emotive stories that really moved us in regards to our passions in EMS. So without further ado, we'd love to introduce our all-star panel.
Hi, I'm Bex. My Twitter handle is Medibrat.
Medibrat.
Hey guys, it's Mike Perlmutter at DitchJock14.
It's Andrew Merleman. It's at AMERELMAN.
Good evening, everybody. Mike Brown at Firemedic FPC.
There it is. Fast 19 is in its second iteration, followed after obviously last year Fast 18, but it's certainly a collection of, I think, folks who are social media oriented. And I think that's one of the most incredible things about the foam world is that many of us have found one another through social media and actually formed lifelong friendships. And coming to Fast 19 actually feels palpably like that, like you're meeting your people, like you're meeting your tribe, and you're kind of with your community. I don't know what your thoughts are on that.
Yeah, I totally agree. It's pretty surreal to meet a bunch of people that you've only interacted with in social media, on Twitter, and you show up. I was talking to somebody today. We had a probably 20-minute conversation before I realized it's someone I've been talking to on Twitter for 4 years. So it's amazing how different people are in person, and it's cool to connect with them in the real world setting.
Yeah, I think it's an incredible community of people from, I was shocked actually how far people have come to this conference, and just this all-star group of people who are just looking to do pre-hospital care at a whole other level. It's amazing.
I think one of the themes of today also was not only high quality clinical care, but the art in medicine and the art that is underlying our passion. And I think there was no better choice for the opening keynote this morning, our very good dear friend, Ginger Locke. What do you guys think about her opening session?
I thought it was fantastic. She mentioned having the artistic qualities beaten out of us in paramedic school, and she's not wrong. And sadly, we require it. We spend our lives and our careers making order out of chaos, and we need that artistic ability to, for lack of a better term, MacGyver all of our calls and situations, and it puts a much better spin on things. Nothing's ever black and white. Mm-hmm. We do so much better with the creative aspects.
And when you approach a patient, you're not right away thinking about a study you read or some science-based fact that you learned. You're looking at the patient and applying experience, knowledge, whatever background you have that's led you to this point, and you're framing it with that, balanced with the science that you know. That mix is really what she described as the intersection of art and science, is where medicine exists. And I think we're all taught that, but we forget it, especially in the foam world. We're all very science-based. All the articles are based on literature, data, and you lose a little bit of that clinical aspect of the experience. So I think that's the art portion that she was trying to get at.
What's fascinating to me is she's coming from the perspective of an educator. And what she's found to be most effective in creating lifelong learners is using art to actually spark a passion that her students didn't know existed within themselves. And that to me is fascinating. I know certainly within EMS, we may descend from a paramilitaristic tradition, and there's a regimented order, a hierarchy, a class system in regards to ranking, etc., within fire systems within the US, etc. But nevertheless, in medicine, it's about sparking that human connection with your patient, building rapport, trying to understand them on a deeper level than just their medical diagnoses, medical conditions, or emergent condition. And then also in regards to fostering the community of people that are attending this conference and igniting that spark, so we carry that torch with us back to our home institution and say, hey, it's not just a job, this is a profession. There are certain characteristics we can hone and develop to really make this a lifelong profession.
Yeah, and I think I was really struck throughout this whole conference just that the way people learn, I think the more we talk and the FOMED movement goes, it's all about human stories, right? It's about what's the story of this patient. The way we learn is through telling stories. I think Dr. Antebi's talk today about the Parkland shooting, Bax's talk about the emotional toll of what we do, thinking back about Ashley Liebig talking about how we lecture and how we teach. It's just such an important thing to remember that the art of medicine, I think, is very much related to storytelling and what the nature of the story is that we tell and how that shapes how we take care of patients, how we see patients, how we interact with patients. I've just been very struck by that component of this whole conference.
Some great foreshadowing about the remaining lectures of the day, Mike.
Yeah.
I like that.
Definitely.
So following Ginger, which was a very tough act, I had the privilege of presenting a very science-based talk in comparison to my discussion last year on the limbic system and PTSD as a personal story. But one of my goals here in discussing essentially intrathoracic pressure regulation in cardiac arrest was to illustrate a very straightforward concept that we may intrinsically understand and or experience on a regular and or daily basis, but nevertheless lives in our subconscious and not in our conscious mind. So what we're talking about is cardiac arrest. We are all familiar with compression rate and compression depth. And what I was trying to dig into was the physiology of the recoil phase. And recoil is actually incredibly important in cardiac arrest, or ACLS algorithm does not work without recoil. And we all think about compressions in delivering forward flow or moving blood outside the left ventricle to the remainder of the body. But one thing that we have to be conscientious of is recoil allows for preload. In other words, 3 distinct functions are happening during the recoil phase, I think, that are worthwhile in discussing. Number 1, blood is entering back into the right side of the heart. So whether that's from the IVC or the SVC, blood is coming back to the right side of the heart via negative thoracic pressure. It's being pulled in via vacuum. Number 1. Number 2, blood from the lungs is also moving forward to the left side of the heart so that your left ventricle is now filled for the next subsequent compression. And I think what we're learning is increasingly important is that your ICP is also reduced during the recoil phase. I think somebody I gather a lot of inspiration from is Dr. Keith Lurie, who's pioneered this very niche aspect of medicine in cardiac arrest. Each compression can potentially be a concussion, meaning we all are focused on ROSC as our primary outcome, but really have to think about intact neurologic hospital discharge. So recoil is multifactorial and allows those 3 things to happen: blood to come back to the right side of the heart, blood to advance to the left side of the heart, and a reduction in ICP.
I really think it was that ICP reduction that really struck home for me the most. And obviously being a fire-based provider, I do end up doing a lot of chest compressions. So it really drove home for me how important it is that we're rotating compressors regularly. And real quick, while I'm thinking about it, we had a really nice conversation, a follow-up question that you kind of entertained at the table that we were sitting at, the other folks that were there, on mechanical CPR. And if you could just kind of dig into that a little deeper. Faison, you had a really nice answer for them at the table.
Yeah, I think, really my philosophy for 2019 is focusing on the basics. Just like I have a newborn at home, clearly she's learning to crawl before she's going to walk and run. And I think cardiac arrest is very similar. I think there's a tendency in all of medicine, not just pre-hospital medicine, to be distracted by shiny toys. High-quality CPR is something that we should not only strive towards, but to be perfectly honest, in 2019 should be a requirement. But when we look back at some of the incredible prospective EMS research that has been performed, primarily the ROC Consortium and their work, the Research Outcomes Consortium, and looking at the PRIME ED study, which looked prospectively multi-center, placebo-controlled, double-blind at cardiac arrest in the United States of America, and their intervention was the ITD, or impedance threshold device, with active compression decompression. They found no difference. But when they actually dug into the data, they found that only 27% of their greater than 8,000 patients received high-performance CPR, and those were under very loose definition set out by the AHA. So that to me in itself is staggering. And when we talk about the discrepancies in EMS practice, that's one of the reasons that we started the EMSNation podcast, is why is it that you can be in one county and have incredible cardiac arrest outcomes? Like, I want to code where Mike lives if I'm going to code at all. Preferably not, to be honest.
Right.
But why is it that one system can deliver incredible outcomes, whereas a neighboring county can be significantly below the nation's average? So when they took greater than 8,000 patients, only 27% received high quality CPR, and that in this day and age should simply be unacceptable. About building basic blocks and structures and algorithms and response matrices, etc. So for cardiac arrest, it's typically a multi-agency response depending on where you are. It might be a volunteer BLS squad, it might be a fire engine, it might be a private ALS, but unless you're training together in interagency drills, then how can you ever think that you're coming together to treat or care for a critically ill or injured patient and you're going to operate well in concert? It's just a fallacy.
And I think that's so important because you mentioned where I am in Minneapolis, and I think we've gotten a lot of publicity with the ECMO program that we're running there, and the numbers are great. I mean, I'm continually astonished by how good the results are, but I think we tend to focus on ECMO because it's cool, and it's new and it's shiny and it's pretty neat to watch, but I think what doesn't get talked about quite so much is the training and practice that goes on in the background to deliver really high quality CPR in the field, and then continue that on the way in to get ECMO and to get into the cath lab and open up whatever that culprit lesion is. But I think I agree with Faison. 27% getting high quality CPR is just, in this day and age, is just not okay.
Well, and that's what's so important if we want to see those ECMO programs expand and succeed, that we've got to work on that no flow time. That CPR has to be, we've got to improve the basics, like Faison said. Otherwise, we're going to have that push to get people to ECMO, and we're not going to see the results that we want to see because they had 10 minutes of no flow time in the field before we were able to get them, get care started and get them to ECMO. So it's going to kind of skew those numbers in a way that isn't going to help the technology to really be able to grow the way that it should.
When we look at the programs that are actually deploying pre-hospital ECMO, they have years of high-quality CPR training. And I know Charlie Lick and RJ Frasco have been incredible EMS medical directors in the Twin Cities and have worked and strived for developing these systems of pre-hospital response to cardiac arrest. And that's why the integration amongst all the specialties is also exceptional, because EMS is integrating directly with the cardiologist, the interventionalist, the ICU, and it's really the continuum of care. So I think that's exceptional care, and it's something that we should all strive and model towards.
Yeah, and I think that idea of EMS as an integrated part of the healthcare system is just a very forward-looking thing, right? Because we talk about this, I think been a huge part of the debate lately is where does EMS fit into the larger healthcare system? And I think historically it's sort of been its own piece, and now we're seeing that if we want good outcomes, these good neurologically intact survival rates and meaningful recoveries for patients, it has to be an integrated system of care that works with other parts of the healthcare system to deliver these outcomes for patients.
In regards to systems of care, next up we had Alan Wolf of Air Methods talk about challenging airway scenarios in the setting of facial trauma.
This is a gnarly facial trauma. I'm just going to say that.
It was crazy.
It was pretty gnarly.
How would you guys describe it for our listeners?
Devastating.
Yeah. Life-changing, devastating trauma. Yeah.
It's the classic facial trauma after a shotgun injury, so not much to work with.
So use your creative imaginations, but there was very little left of the face.
Yeah.
The patient was barely protecting his airway and needed an advanced airway.
However, was conscious and alert and following commands.
Yeah.
Which is even more frightening.
And he was requiring pretty aggressive suctioning, though. He was bleeding quite a bit, so it wasn't like they had a lot of time to... He obviously needed advanced airway, where some of these patients are sitting up and they're doing pretty well on their own, but this guy obviously... He showed some photos and video, and this guy clearly needed to be managed.
He talked a little bit about his algorithm in regards to approaching the challenging airway. What were your thoughts on that?
I think him talking about the heaven, or sort of leading into the heaven criteria, and also, see now I can't remember the mnemonic or what have you. I think it was interesting listening to him talk about how to look at these airways and think about what your priorities are and how to approach an airway like that, and think about what are the pros and cons of one or the other. And one of the interesting things that came out of that for me was after his talk, talking to some other people in the audience, talking to Jim DeCanto and some others just about how they would do it. And it was interesting because people had just very different views on how to do it. And I think it's such an individual patient approach. You know, are you going to do it awake? Are you going to do it not awake? Are you going to go supraglottic? Are you going to go surgical approach? Just super interesting stuff.
And he highlighted the importance of, you know, everyone needs oxygenation. So even someone with a very complicated airway, you have to focus on the basics. Mm-hmm. But this patient had no mandible, essentially, no soft tissue to work with around the face. So you really couldn't bag them. NRB would have been challenging. So the way they kind of improvised was very interesting.
You want to describe that more, Andrew?
I think they ultimately ended up intubating him orally. I can't recall what they did for basic oxygenation before.
Yeah, I didn't think it was super clear because one of the things he talked about in the talk was that you, with a Lefort fracture like that, you can't really bag valve mask. Right. You can't fall back on the basics.
Nothing to seal it.
Right. Yeah. And so it wasn't super clear to me what the pre-ox technique would have been, or even if that's...
They kind of jumped right into...
There was real no nose that you could apply.
Yeah, there's no nose, no nasal cannula.
Yeah, I think they're primarily using blow-by oxygen.
Yeah.
He kind of talked about that less is more concept, and that's kind of what happened with this patient pre-hospitally from what he was saying. You know, it just kind of was allowed to sit up and maintain their own airway, which depending on what kind of airframe you're in, if you're flying or, you know, what kind of ambulance you have, that may or may not be an option for you, for somebody to be able to just sit up all the way and be able to allow the blood and secretions and things to drain from that airway. Mm-hmm. And I think the other consideration that you have to take there is if it's not a short transport time, you're going to deal with some swelling that's going to start to complicate things very quickly if you have any kind of length of transport. So I think that's an area where you have to be a little aggressive and ready to take that airway before transport, because that's not something that you want to deal with intra-transport. Now you have an airway that's swelling shut, that's been disrupted in the way that this one was.
Yeah, and they had the wherewithal to prepare for a surgical airway if needed, and I think primarily the intervention was incredible communication with the emergency department. Anesthesia was on scene and standing by. And I think even some of the surgical staff were on scene to prepare for a potential surgical airway.
Yeah.
So some of these cases that I love talking about are halo cases, high acuity but very low occurrence, that generate some fantastic conversation, because we may all have different approaches in regards to the management ultimately, but there is no single right answer.
Yeah.
I think it sparked a really interesting side conversation with us and a couple other people. If you're presented with that, is there a value to going straight to a surgical approach? Because like you were saying, you're faced with that swelling and that edema, how much time do you have? And it seems to me the consistent thing that comes up with surgical approaches is that we wait too long, right? I mean, they're successful, but they fail because we waited too long. And so for a patient like this, but it's complicated by the fact that he's awake. So I don't know, it's a tough one.
The fact that he's awake, though, gives you more time and more options. So they ultimately ended up doing a light sedation intubation. I'm not sure whether or not they tried to topicalize the airway or anything like that. I can't remember if he mentioned that.
I don't think he did.
Yeah, but they mentioned that their goal was to keep him breathing. And if the patient's awake, you have the benefit of that option. You're not forced to rush things. It sounds like this guy was oxygenating fairly well. They emphasized suctioning. They were suctioning. I think they had him suction himself a little bit, and that was enough so that they had some time to make a decision and try to prevent desaturation. Like we said, there's not a lot of time. There's not going to be a lot of time to try to intubate him. So Mike was saying, you know, there's a value to going straight to surgical airway. There might be, but there's you have to have a very low threshold for surgical airway, whether you're going to try to intubate or not. So I would assume if they were to, you know, have any sort of extended laryngoscopy, they would have abandoned that and moved right to a surgical airway. I think that would be the responsible thing to do. But one thing that they didn't talk about with this case that I know our friend George Kovac would certainly bring up is a true awake approach. And I know he has intubated many patients like this with flexible endoscopes and just topicalization. Now Mike and I were talking about how difficult it would be to actually topicalize someone's airway when there's so much facial trauma and so much blood.
Yeah.
But it's certainly something to consider because some of these patients tolerate it very well if they're cooperative. So there's a lot of value in not giving any sedative and hopefully maintaining that respiratory drive the whole time. Whereas I think they used midazolam, if I'm not mistaken.
Midazolam and fentanyl.
Yeah, which is an approach that has potential to decrease respiratory drive, and then you end up in a situation where your patient's not breathing, and then your hand is forced. So if you can keep someone breathing, you can try an awake approach or a ketamine only approach, which would allow you to typically maintain the patient's respiratory drive.
In regards to ketamine, Andrew, I think that's a perfect transition to our next topic of the morning. Our very good friend Dave Olvera, also from Air Methods, was discussing the potential of ketamine. And I think actually in EMS, it's difficult for me to say this, but the pendulum may have swung too far. What do y'all think? I know we have some ketamine experts in the room, so.
Yeah, this was a super interesting talk. At first I was a little put off, and I think by the end I was appreciating his points a little bit more, which I think was that idea that you were just saying, that maybe it's swung a little too far, and we've had, in my own experience, we've had a little bit of indication creep. We've had issues trying to figure out optimal dosing and how we deliver that dose to get the effect that we want. So I think there's definitely caution warranted. I think Andrew and I have had a lot of discussion about how to use the medication safely and understanding what its complications potentially are and how to respond to those complications, making sure we're equipped to respond to those complications. So it was definitely a thought-provoking talk. It was definitely against the grain, because I think we were very quick to adopt ketamine and kind of embrace it. And I certainly do, but it was definitely an interesting talk.
I think there towards the end, though, he did kind of bring it back to the grain and talk about how it's more about the resuscitation than the drug. So, the combination of everything that's happening, the need for fluid resus or blood or pressors or, those things that maybe we need to do in conjunction with the ketamine usage. So it's more about that holistic look at the entire patient instead of just the drug kind of tying in.
It's not just about ketamine.
Yeah, it's not just about ketamine. Exactly. It's tying in the art. It's the art and the science, right?
And as an osteopathic medical student, I very much appreciate the holistic approach to a patient care. But no, it's very important to realize ketamine is not a one-size-fits-all drug. It's part of as Jeff Jarvis would put, it's part of a package of care, right? It's a drug that we know has benefits in certain patient subsets, but you have to use it appropriately. Always have to use it appropriately. You have to dose it properly, and you have to understand its most common side effects, which frequently most cited is like the dysphoric reactions or the fact that ketamine can decrease your blood pressure. I don't think anyone is trying to sell ketamine as something that's always going to increase someone's blood pressure. Every time I've learned about ketamine, there's always been the caveat that, like with any sedative, it will decrease your blood pressure. And this is one of the things Dave harped on in his talk, was, you can't go to intubate the hypotensive patient and expect ketamine to save the day. That's not realistic. We know we can't do that. One thing that's important to mention, though, is if you dose it appropriately, it might be better than other agents it might be less likely to decrease the blood pressure than other agents like etomidate or propofol.
I think actually his experience with ketamine, especially in his trauma subset, is very consistent with our own data sets in New Jersey. And ketamine actually, when you think about the ideal patient to implement ketamine on, you have to consider what their endogenous catechol reserve is. The area where ketamine can really shine is when they have reserve and they have access to additional catechols that ketamine can keep in the synapse and actually promote your hemodynamics to safely intubate the patient, because peri-intubation hypoxia and hypotension are very real and very harmful. I think just like in trauma patients where we have definitive data that vasopressor use in hypotensive trauma patients is bad, I think ketamine follows that same angle. Like, we have to think about damage control, resuscitation, and permissive hypotension. So I'm not surprised whatsoever that in his trauma subset that those patients had in fact had poorer outcomes. I think we have to be judicious with its use and think about its actual indications and the patient that we're implementing in as part of our, medical decision making as resuscitationists.
Mm-hmm.
And I think the paper, I think Miller from the Sydney Hems group a few years ago looking at shock index with ketamine use, if I could get LifePak and Zoll to bend to my will, I would put a shock index box on those monitors so you would just see it. That would just be part of our vital signs, because I think that paper showed really nicely that the more shocky you are, the more likely it is that ketamine is going to have a negative effect on hemodynamic status, just like anything else. And I think about Rick Dutton at Shock Trauma, or formerly at Shock Trauma, and saying, those are without question the sickest trauma patients that you can find. And Rick would say, you can induce anybody with anything, right? You can use propofol, it's fine. You're just going to use 10 milligrams or 20 milligrams, not 200 milligrams.
Yeah.
But you have to have that art and science and medicine to look at the patient and say, this patient needs 20 of propofol, not 200 of propofol. And I think ketamine has to be the same way. We have to look at these patients and say, they have no blood pressure, they have a heart rate that's super high. We have to dose appropriately.
Have you already been talking to them about that shock index box? Because that would be awesome.
I think it'd be great. I think it'd be super sweet.
Yeah. Very valuable.
In regards to shock, Ashley Liebig brought to the table something that needed to be discussed, and that is the element of decision fatigue, or the concept that we have a finite number of decisions we can make, especially in regards to patient care or critical medical decision making during the course of the day. And the more decisions we make, the later in the day it is, the more compromised our nutrition is. We may not hold a strict high standards at the end of a clinical day that we do in the beginning of the day.
Yeah, she used a great analogy that I really liked, and she said that you have to think of the decisions you make throughout the day as a matchbook, and every time you burn one of those matches, that's energy you're using, and that's one fewer match you have to use. So if you think of each decision like one of those matches, you have a finite amount of energy to expend throughout the day. It helps to make your big decisions earlier in the day and to try to break up big decisions into smaller ones so you're not expending so much energy on one thing.
Yeah, I think an interesting aspect of this conference and a lot of the FOAMed stuff has been sort of the cognitive science of how we resuscitate and how we do our care. There's been a lot of discussion about checklists and about sort of protocolized care, and I think cognitive offloading is such a big thing. I think if you can simulate and train and educate and have resources like, we were talking a little bit about Dr. Antevi, the Hantevi app, and other things like that let you offload some of the bandwidth that's required to make these decisions. I think we might see a real improvement in how we make decisions about patient care, especially as the day goes on. If it's your fourth or fifth critical case of the day and you're pretty much out of matches, I think it's good to have some tools to help you make good decisions.
And one important way to do that in high-performing systems, they are very standardized and protocolized, and they've prepared in advance for these systems. So they're minimizing the number of decisions that their providers have to make. They're using checklists like Mike mentioned. They're using standard procedures that they've trained, they're orchestrated, and that significantly reduces cognitive burden and this decision fatigue.
And Ashley mentioned it's not just the work decisions, it's the home decisions. It's little things like, what are you going to have for dinner? Where are you going for dinner? And how the decision fatigue at the end of an especially busy shift just affects your personal life and affects everything else. And how you need to be able to say to whoever's at home with you, or your coworkers if it's before the end of shift, look, I'm basically emotionally tapped out. I'm beyond decision. I don't care what we eat. Just choose something.
Yeah, and she talked about a couple things that really rang home for me really well, and having 5 attainable goals for each day, and then trying to make those important decisions early. Kind of going back to that matchbook analogy. So while you've got the matches, spend it on something. So when it's cold out, make sure you're starting the fire when it's cold out. So make those important decisions early. And something else that really rang home for me was a kind of a follow-up question that Tyler had at the end about asking medical control for orders. Because you have to think, if a physician, you don't know where they are in their day or where they are in the process of everything that they're dealing with in that emergency department, and is the easiest decision for them to say no, yes, that is going to be the easiest decision. So if I want to do everything I can to paint a picture for them and make sure that I'm very clear in asking what I want, so that I'm helping them to be able to make that decision that's something other than no. That kind of helped me bring everything that Ashley had to talk about into something that was really going to be beneficial in my workflow.
I think that's a perfect transition for our next speaker, Dr. Mike Abernethy, that really was talking about the role of an EMS physician, which is still a relatively new concept.
Certainly in the United States, I mean, you look at a lot of the pre-hospital systems in Australia or the UK, they're much more physician heavy than we are in the United States. And in those countries, they're using their physicians to provide a higher level of pre-hospital care. And like he said, more of a higher level of decision making. It's not necessarily about the more advanced procedures, which he mentioned. It's more about the fact that an EM physician coming out of residency has already seen 10,000 plus patients, which is far more than any pre-hospital provider is going to see, maybe even in probably not a career, but certainly in their initial training, they'll see nowhere near that number. They just bring a higher level of that ability to make difficult decisions, and they have a very broad differential. And I think a lot of people focus on, oh, hey, we're going to add physicians so that we can do field amputations, which he highlights, it's not really about that. It's about a physician as part of a team to expand the knowledge base and expand the diagnostic and treatment capability of the team.
He was very, very clear about the physician as part of the team, not the head of the team as well. There's a flattening of hierarchies. Just because the physician is a different skill set does not put them in charge all the time.
Yeah. And he was very clear that you can't just put a physician in a fly car and start sending them on calls. They have to be integrated into an EMS system. The providers have to know them, and they have to train together. It has to be a dedicated part of the system. They can't just start showing up on calls. It doesn't really work like that, like it should.
I think one of the highlights that he was also bringing up is now that we under the ACGME have a board certified fellowship for EMS, is really hashing out and developing the administrative aspects of running an EMS program in combination or in concert with the field response. So it really is a new breed of physician that's now formalized under some of our hierarchical structures within the American Board of Emergency Medicine. So something very exciting for the younger generation of EMS physicians that is very empathic, compassionate, and advocates for high quality pre-hospital response amongst all providers.
And he mentioned that, you know, not any doc should be doing pre-hospital care, and that's where this EMS fellowship comes in. And really it's just about selecting the right physician, whether they're EMS fellowship trained or not. It's someone who's received pre-hospital training, that knows the field, that knows what their role in the field is. You shouldn't have dermatologists showing up. Shouldn't have, in many cases, you shouldn't have primary care docs showing up that haven't had pre-hospital training. You have to be the right physician for the job. Someone who's dedicated time and energy into learning how to function in the pre-hospital setting.
In regards to training, something we perpetually feel undertrained on is our approach to pediatrics, especially critically ill pediatrics. And I think our next speaker, Scott DeBoer, did a great job of highlighting some of the key clinical concepts in regards to the approach to sick kids.
Yeah, he gave a very valuable talk where he really reviewed some of the fundamental pediatric things that, you know, if you're not seeing kids regularly, you forget even the basics. You really need a refresher on that, you know, to stay up in the pediatric world. And using resources like HandTevi and similar pediatric pre-hospital references can really help. We don't see these types of patients very often unless you're at a specialized transport team. He had a very engaging and interactive session that let us kind of review our pediatric topics.
I liked his approach as well because it was not condescending. I think many providers are aware that they need to brush up on their critical care pediatrics, and his approach and philosophies were highly encouraging, highly positive, and constructive. And I think that's the type of feedback we need from medical directors, especially for an area of weakness. But it's interesting that this is an area of weakness across the spectrum for many out of hospital and emergency personnel.
I like the pink, warm, and sweet that he brought out to kind of help remember that we need to check those blood sugars, right? We all know that we want our patients obviously to be pink and warm, but bringing in that when those pediatric patients get stressed, they're oftentimes gonna drop their sugars. So I think personally for me, that's probably an area where maybe I might have a little room for improvement, is maybe some better glucose checks. And real quick, I'm gonna rewind just a little bit to the last talk. I didn't get a chance to break in. I'm gonna climb on a soapbox for just a second, because I had a little follow-up conversation with Dr. Abernathy about degree requirements for paramedics. And I think that's some place where folks that are listening to this podcast, this is some place where I think we can help to try to elevate the field. And he talked about where a lot of other countries, it's a 4-year degree to become a paramedic. And I think that's something that we could do to help ourselves out a lot, is improve or increase the number of paramedics that we have that are seeking college degrees to go along with their certifications. Unfortunately, the union that I'm a member of just came out with a position statement that is kind of in contrary to that, but
I appreciate the sentiment, Mike. I'm actually going to refer people to episode 72, where we did a whole podcast on paramedic degree program requirements and some position statements by large agencies across the U.S. So a lot of nuances in that podcast as well. So we'll fast forward through lunch, and then a good friend of ours, Sam Ireland from the Foam Frat podcast, was talking all about BiPAP.
Yeah, I thought this was a really good talk. I was struck, I probably won't remember the phrase exactly, but he ended with this idea of the look that patients on BiPAP have, and that really stuck with me, because I could remember a number of patients of mine who have had that kind of 1,000-yard stare. He did a really good job, I think, of walking through some of the nitty-gritty of BiPAP and how to approach those patients. So
I think that look was just that they looked him in the eye, and that's not something that you ordinarily would get out of your intubated patients. I think it's a little easier to feel that disconnect if somebody's not somebody's not tracking you or looking you right in the
maybe they're
in the eye.
They can't communicate with you really. So I think that's the big thing, is they have this look in their eyes, maybe of fear, because they're so short of breath, but they can't communicate because they have the mask. So it really puts a barrier, and I think that's what kind of creates a little bit of fear in us when we're treating these types of patients.
How do you describe some of the reassessments about patients in BiPAP? How do you determine if they're actually failing BiPAP?
I think we had some interesting conversations about sedation on BiPAP and getting patients to tolerate BiPAP. And the other half of that was a few of us were sort of jokingly saying that a lot of these patients don't need sedation because they've got hypercarbic encephalopathy. When you get there, and how do you know if they're failing BiPAP? By either the Untitled CO2 reading being super high, or a VBG or an ABG where the PCO2 is just sky high, and then you've got to reevaluate. Is this BiPAP failing? Is this my BiPAP settings that are failing? And just kind of take a fresh look and say, what does this patient actually need?
Well, I think even in absence of ABGs, if you don't have those available to you, are VTEs, and I think that's something that gets overlooked. Oftentimes, people don't keep as close an eye on what they're getting out as what they think they're putting in. So it's that tidal volume exhaled, and making sure that we're meeting the needs of the patient with what's coming back out. Because if it's not coming back out, it's not going in.
Yeah, absolutely. So when you are choosing your settings, you want to see what type of volumes your patient is tolerating and essentially producing to determine if they're getting adequate ventilation. I think that's incredibly important.
One of the main points he talked about was how to treat type 1 versus type 2 respiratory failure and how to adjust your settings appropriately. And basically he was saying that type 1 respiratory failure, which is a primary oxygenation problem, so they're hypoxic, you're focusing on your PEEP, so your lower number, you're focusing on PEEP, so that by increasing that lower number, you're recruiting more alveoli and you're improving oxygenation. Whereas in your type 2 respiratory failures, your hypercarbic respiratory failures, you want to provide more volume, so that's going to be your top number. So by increasing that, you provide more volume that they can use to get that CO2 out. and improve their exhalation so that they're clearing that CO2. So by adjusting those two numbers accordingly, you can treat various types of respiratory problems, where, for example, your acute pulmonary edema would be a type 1, or a severe COPD would be a type 2. So very different approaches on BiPAP. You don't want to put everyone on the same settings.
Yeah, I thought it was kind of cool. For the top side, he used a shovel for the for the picture there to show that you're helping to get that out.
Next up, we had James Boomhauer from Boston MedFlight give an incredible talk on being fit for duty and some of the mental health challenges and experiences we have on a essentially near daily basis, especially in pre-hospital response when you're dealing with people who are having the worst day of their lives.
James has some crazy, hairy stories that he tells. Yeah. He sounds like they've made really, really good inroads within the service, within peer support. And he said we have to be our own advocates. We have to be our own biggest fans. And I really liked how he pointed out when his partner was checking on him, it was, how are you doing? Can I call? As soon as she realized there was something up.
You have to realize that when you say, are you okay, it's purposeful, and it's not, he said it sounds like we're saying it in cursive a lot of the time, where it's like, are you okay? And then you move on. But he wants people to say, are you okay, very directly, and make it known among your service that when people ask that, it's a purposeful question, and it's okay to talk about those things. And after calls that might be more challenging, it's very important to debrief and talk with the crew, talk to maybe if you have some sort of support staff that work at your service, to involve them and just debrief. There's no shame, and it certainly can help with that emotional offloading after tough situations.
Well, I think even in the situations that aren't tough, because he talked about how it's not always the call that's the stressor. Sometimes it's that accumulation of calls, or it's everything else that's going on in life along with that call that becomes the stressor. So I think that's where it's important to see that peer support is so much more beneficial in my opinion, and I think a lot of studies have also shown that, when compared to like critical incident stress debriefings and things like that, it's going to catch more of that cumulative stress that maybe isn't just a response to one particular thing. And I kind of had an interesting one-off with James after his talk, and he said he'd like to see peer support become as mainstream as capnography. Mm-hmm. That's a great place for us to try to get to, because everybody's doing capnography, right? So everybody should be doing peer support, because it's, he gave the interesting statistic that it's 1 in 10 EMS workers that commit suicide, and that doesn't include the ones that left the field. So that's a staggering statistic, and that's horrible. We see the same thing in fire and police. We lose more to suicide than we do to line of duty death every year, and it's continuing to get worse and worse. And we've got to do something to break the cycle. We've got to decrease the stigma. We've got to get people to understand that it's okay to not be okay.
Well said. It's scary the way the psychological toll is escalating. I think one of the key components why CISM, critical incident stress management, was shown to be in fact harmful and has quickly fallen out of favor is that it was mandatory. And I think that was a nuance in his approach, but his peer support personnel very kindly requested to see if he was available for a call or would be amenable or open to having a conversation. And it was more an invitation to discuss rather than a command. And I think just framing it cognitively in that different perspective is inherently significantly more compassionate. Like, I can just, as your colleague and peer, I see something is wrong with you and I want to have a genuine and open conversation. Is that something you would be willing to have with me? And I think it's up to that person to say yes, no, maybe later.
Coming from a service, shout out to Ottawa, where we have a very well organized, very well founded peer support system, I saw a lot of similarities. There's, after a major disaster or a big call, peer support is always available. They may approach you immediately after the call and ask, Are you okay? Would you like to talk? But they're available to everyone all the time. It's like Mike said, it's not always the call that is the stressor. And sometimes that's just the final straw. And we have the ability to call in and say, I need peer support, I need them now. And we are immediately pulled off the road until we've talked, and then we can choose to go back on the road, or we can choose to go home. And there is no punishment, no stigma, no judgment. They're there for our benefit. And it's made a huge difference with us so far that I've seen.
Yeah, I definitely hope that we continue to dedicate resources as a community in investigating this and developing systems that are robust and really foster resilience amongst a profession that is inherently challenging. There's no way of getting around that. In regards to clinical challenges, every once in a while we will see patients with acute decompensated heart failure in a catechol crisis. And this is a topic very near and dear to my heart. Mike, tell us why you're so passionate about this. IV nitroglycerin.
This has been years of thinking, mostly because of one call that really stuck with me. And I think it dovetails nicely with the are you okay and the peer support and just the emotional toll of it, because I think there are patients who just stick with you, that you don't leave behind, whether or not it goes well or goes poorly, you just keep thinking about them. So I had a lady some years ago who was very, very ill with decompensated heart failure and it was kind of your classic case of just fluid up to her eyeballs, and it sounded like a milkshake slurping the last little bit out of the cup, and a blood pressure that was sky high. And the outcome was not so good doing what we conventionally do with sublingual nitro and CPAP, and I spent a lot of time thinking about why her outcome was so bad and what could we do to make the outcome better. And I think listening to Faison too was a huge inspiration, and just thinking about it more broadly and seeing what can we take from in-hospital care out into the field, kind of Abernathy's idea of it's time to take this stuff outside. So I started looking into literature and seeing that we can give these massive doses of nitro, like 1 milligram, 2 milligrams, so 1,000 micrograms, 2,000 micrograms as an IV bolus, and it's super safe. And we see these huge improvements for patients, and started saying, like, we got to do this, we got to make this happen. And so my service is doing it. I've been talking to a lot of people here that other services are doing it, and so I don't know, we're changing the game, moving the goalpost.
And I know you guys are doing it as a pilot project and prospectively collecting data. Yeah. These again fall into the category, thankfully now, of high acuity, low occurrence. How many patients have you enrolled, and how long do you see data collection going? Because while, again, I have some area of expertise in this topic, the 2 milligram papers didn't have a control arm.
Right.
So the challenge there is, while it was shown to be safe in the emergency department setting, there was no real comparison or comparative group. So again, in terms of research, we have to set up the null hypothesis and say, what are we contrasting this modality against? But certainly conceptually, as pre-hospital care providers, our first intention is to place a patient on positive pressure ventilation. So whether that be CPAP or BiPAP, but then the idea of throwing sublingual nitroglycerin tablets at their face is absolutely farcical. We need to implement some other intervention to reduce their massive afterload.
Yeah, and I think that was one of the central things that I figured out, was that is the problem, is the afterload is just so high that you can't bring it down with sublingual nitro. And every time you take that mask off, you're losing that recruitment, you're losing that expansion of alveoli that are just collapsed and atelectatic with pulmonary fluid. I think you bring up a really good point with the research, and I think when you read those papers, there are methodological problems. There's not a good comparison arm. The number of patients that are enrolled is relatively low. In the 2 papers from the US, it's a very specific subset of the population, and you have to ask how well can that be extrapolated out to the population at large. So, and I think your point is super well taken, that it's a very high risk and low frequency event. So in our system, we think we see somewhere in the neighborhood of about 100 patients a year who would qualify. So our plan is to prospectively collect data for 12 to 18 months and go from there. But it's not a randomized trial. And I think it's a perfect illustration of that pre-hospital research needs specialists, it needs time, it needs money, because it's really hard to do. It's very hard to randomize patients in a pre-hospital setting to one therapy or another. So the goal is to see what these patients do from a safety perspective, and then hopefully move forward into more detailed work about comparative therapy. So we'll see what happens.
Something I thought that was interesting that you discussed with some of the early data, the bolus alone was better than the drip or the bolus followed up by the infusion.
Yeah, I thought that was super fascinating. In this study, they randomized patients to, so this is open label. So again, not the standard of a double-blind RCT, but randomized patients to either get a bolus or a bolus and a drip or just the drip. And the primary outcome was ICU admission. And the patients that had the bolus alone had a statistically lower rate of ICU admission, which I just think is fascinating. And I think needs to be explored further.
Yeah, I think there, again, was a fair bit of selection bias amongst the providers.
Definitely.
Here, kind of similar to the ketamine is, you have a sicker patient, your hope is to use ketamine as a panacea, essentially. But this is a remarkable area of further research, and we look forward to hearing some of your data, Mike.
Yeah, we're looking forward to it. I hope we can share and figure out a little better how to take care of these patients because they're just so sick.
So a few more talks in the afternoon and evening to wrap up the day. We had Chris Meeks talking about how to ventilate the dead.
Yeah, he gave a really interesting talk on using mechanical ventilators during cardiac arrest. And he was talking about some data that he was collecting on cadaver models that showed potentially better physiologic parameters with mechanical ventilation compared to no mechanical ventilation during chest compressions. And this is really interesting. His premise was that they started looking at it because they wanted to see, can we safely use a ventilator in situations where there's only two providers in the back of a helicopter. But it sounds like they may have found some more interesting data that they want to mine into a little bit more that he couldn't really talk about. But his big thing was we should probably be using mechanical ventilators during cardiac arrest to optimize ventilation and to free up providers.
I think an interesting perspective there in regards to the physiology or pathophysiology of a patient in cardiac arrest. The number one malady is leaning on the chest and not allowing appropriate recoil. And the number two malady is, in fact, hyperventilation. So something I'm curious about there is, could you potentially use a ventilator, silence the alarms, and cognitively offload it, set your rate for breaths to be delivered, and essentially then be guaranteed that you're not going to hyperventilate the patient? I think that's no matter how much teaching we do, whether it's out of hospital or in hospital, even respiratory therapists are often unaware. And I think it's the inherent human nature in an arrest situation to try and do everything that you can. But, compressing at a rate that's too high or ventilating at a rate that's too high is, in fact, in these physiologic models, creating patient settings and making them unresuscitatable. And this is not something I think we do consciously, but it's something that, we need to continue to explore creatively.
As we've gotten more and more data about the harms of ventilation, of hyperventilation, overventilation in cardiac arrest, we've tried to approach this in all kinds of different ways, right? The timers, these new bag valve masks that won't let you squeeze them too hard or too fast, the ITD devices that have lights for timing devices. We've tried all these different things, but I think you're right. At the end of the day, it's still someone whose heart is beating really hard, who's cognitively overloaded, who isn't delivering a uniform number of breaths or volume of breaths. I think this is a fascinating concept if we could integrate ventilators into cardiac arrest management, especially as more and more agencies are incorporating ventilators into their standard, daily practice, their daily care. I think it's super interesting.
Well, the care of the ventilated patient is what the next topic of conversation was, none other than Dr. Jeff Jarvis talking about the perils of peri-intubation hypoxia.
Yeah, Jeff did some amazing work with his EMS system in optimizing how they perform RSI, or now delayed sequence intubation. They're doing essentially all delayed sequence intubation for any patient they intubate that's not in cardiac arrest. He was specifically talking about their study, which was implementation of a clinical bundle to reduce out-of-hospital peri-intubation hypoxia. And it was a before and after study, and they looked at implementing a bundle which included a proper patient positioning, which is elevated head or sniffing position, apneic oxygenation, delayed sequence intubation, a goal-directed pre-oxygenation. So they found obviously a significantly improved rate of desaturation during intubation. The results are pretty much speak for themselves, and they're very logical. Yes, we should try to oxygenate our patients maximally before we intubate and during intubation. This is very, very logical things, very simple changes to make to really improve the outcomes of our rapid sequence intubation patients.
Yeah, and I think his graphic, we were instructed to ooh and ah appropriately at his waterfall plot, and I appreciate it. I think I enjoy that figure from that paper more than any figure I think I've seen published in the last 5 years or so. But it was a great discussion of how to use graphics to illustrate the results of these scientific papers to make them understandable. And I think that graph tells you everything you need to know. It's so beautifully clear that by implementing this bundle of care, the rates of peri-intubation hypoxia just are so much lower. It's really very impressive.
He started off his talk, and so this is the third time I've heard him give his peri-intubation hypoxia talk, and I think each time I take something additional from it. And he started off with talking about the patient that had an adverse event during an intubation that occurred with the service that he supervises, and he kind of ended that up with a couple of quotes that really struck a lot with me. And he said, "It's okay to say I don't know as long as you go figure it out." So I think that really gave me that thirst, and I think it gave a lot of other people that thirst to say, hey, it's okay to say I don't know this or say I don't understand this as long as at the end of the day I go figure it out. He also said not saying I was wrong will keep you from improving. So it's okay to say that we were wrong, because that's going to help us be a better version of what we are. So it's going to help us sharpen that edge and constantly push that.
I'm so grateful that you mentioned that. One of the things that I've taken away from FAST 18 was in fact from the keynote Master Chief Byers. And his key takeaway as, performing in very challenging circumstances as part of our military was strength through humility. Those are words that have stuck with me certainly over the entire year since our last conference, and I think I've really taken that to heart, is through displaying humility and vulnerability, we all become better, not only in our own personal practice, but as team members.
Yeah, I just think that opens up an entire growth mindset and just opens up the possibilities of what you can do and take care of patients better if you have that mentality of just what can I learn today? What can I do better from my mistakes? It's incredibly powerful.
In regards to caring for our patients better, it seems to me that it would be logical that we would have very well-functioning or high-performing teams. But in a lot of scenarios, there is this element or theme of hazing among EMS personnel. And our dear friend Rebecca was discussing some of these concepts and sharing some of her personal experiences about what she's observed.
It's something I've seen over the years, how the more experienced paramedics, they joke about having a culture within the system of eating our young, and how we expect our students are fine, we lead them, we teach them what they need to know, we make sure they've always got a safety net. And then as soon as the students put on the service uniform, we basically, for lack of a better word, we behave like adult birds and kick them out of the nest, whether they're ready or not. And I use the term sink or swim, but it's fly or fall. There's a couple of memes floating around the internet about exactly that. And I've seen it, not so much in the service I'm in now, but in the last service I worked for, I saw it breaking brand new paramedics within the space of 6 months. They were miserable and they were jaded and they were surly. And we need to change it. It's an attitude, it's a culture, and it needs to go the way of backboards and mast pants, and it just needs to stop.
What are mast pants? I'm just kidding.
That's the dinosaur in me.
Bex, one of the questions I wanted to ask you is, I know we sometimes jokingly refer to our generation as millennials, but millennials do have a different work ethic in certain regards, and I know some of the criticism of the generation is that there's a sense of entitlement without having, put in the work or the effort or not having gained the experience. How do you kind of like balance those ideas of nurturing admonishment and mentorship versus, really bringing an appropriate effort to the job and bringing the seriousness that it deserves? How are those ideas that you sort of reconcile in your mind?
This isn't an attitude problem from the younger generation. This is an attitude problem from the more experienced paramedics. The ones that have only had a few years experience that are already doing it learned it from the older ones. And it's been there from... I talked to somebody today who has 35 years in, and he said, was there when I started. So I've got 21 years in. It's been there since I started. It has nothing to do with millennials or the work effort put in or anything like that. There's always a little bit of tough love in our learning scenarios. There has to be the tough love. We have to learn to function on our own. There's only one of us in the back normally. But you're a team. It doesn't mean that they have to be without a safety net. You should be, rather than belittling your partner and saying, you figure it out. You're the paramedic now, you deal with it. We should be supporting them. And you can ask them, you can poke them in the right direction. Or you can say, okay, I'll make the decision and we're going to talk about it afterwards. There's so much learning to be done, and it goes both ways. I learn something from the new people every single day.
I think a lot of what drives that is people say, well, I went through it, so now I'm going to put them through it. And then we hide behind the guise of, well, I'm trying to help them be prepared to make decisions under stress or handle these situations when they're stressed. So I'm going to exert this on them. And it's quite frankly just a bunch of bull. And we really need to, now's the time when we can break that cycle, and we're trying to bring awareness to a lot of things that maybe we haven't been aware of in the past.
You're right, it is a bunch of bull. The number one answer I got when I asked people, either why do you think you were treated badly, or why did you treat new paramedics badly, was because, well, that's just the way we've always done it. I'm really sorry, but that's not a good enough reason. We need to change it.
How do you change that culture?
You start with yourself. Recognize the behavior and stop it. Just stop doing it. You have to be really, really mindful of how you're treating other people. We go out of our way to treat our patients with the utmost compassion. Why can't we just extend that to our new paramedics?
Yeah, it's such an interesting philosophy. A parallel in my own experience can certainly be in, the medical school realm. I think a lot of med students, certainly in the time I was training, really did not look forward to the surgical rotation because they were verbally abused. And that was simply the accepted culture. And it's only 6, 7, 8, 9 years later. But in my perspective, that culture is already beginning to change, because that type of behavior that is condescending, vituperative language, and just verbally abusive for no particular reason doesn't have a place in modern medicine. I don't know. We have 2 med students in the house, so I don't know what your thoughts and experiences are in that particular regard. I know you haven't probably quite hit your surgical rotations, but...
I agree. I think that that culture, I guess, really just hazing in medicine is certainly improving. And you see major institutions lately getting called out for problems with hazing and harassment and things like that. It seems like people just aren't really willing to tolerate it anymore. So I think as people continue to speak out, like Bex was saying, and change their own individual behavior, we're going to see more systemic change.
It's something that we've already seen in the fire service, and some of that is because things have come to be more public and with readily available cameras and you're constantly being videoed anymore. We're constantly concerned with what we're doing and things like that. So we've got to try and break that cycle, not only because of how it can affect us in our careers, but how it affects that other person in their career.
One of the cycles which is tragically very difficult to break is the active shooter events, which seem to be perpetually escalating. And Dr. Peter Antevi, who we know as our very friendly pediatric resuscitationist, really brought it home at the end of the day keynote, discussing his experience and directly responding to the Parkland shooting in Florida.
Yeah, he shared a lot of really interesting details about the shooting that I think many of us hadn't heard, and he really tried to pull a lot of valuable lessons out of that.
You could tell how raw his emotional state was and how close to home it hit. And he literally knew all the responders, not only fire EMS, but the police, the SWAT teams that were responding. Gave an incredible illustration of what happened. And one of the takeaways that I had, interestingly, is that all of us have become enamored, many of us, I should say, not all of us, certainly there's skeptics out there, with the rescue task force concept. But one of his takeaways, and something that he has executed very well, is developing these hemostasis kits or stop the bleed kits, which he's done a lot of work in distributing amongst the school systems. So it's simply the role of the bystander in deploying tourniquets, etc., can be invaluable in saving lives.
What's problematic is the rescue task force is not the end-all be-all fix to the situation. I work for a department that has a rescue task force program in place, and I've taught at FDIC and other conferences on active shooter response and the rescue task force concept. Specifically, it's not the end-all be-all. We have to, and it's part of NFPA 3000, so the recent recommendation that came out from NFPA on active shooter response, that we need to have that civilian component. So just like Faison said, oftentimes that person's life clock may have run out long before the rescue task force gets there. So it's about that civilian component and empowering people and training people and equipping people to be able to help others. So, everybody's probably familiar with that run, hide, fight mantra. And, I think we need to look more at that run, hide, help, fight. So if you're hiding, is there something you can do to help someone that's injured that you're hiding with?
What's fascinating to me about this shooting, and I think most people are not aware of this, is in fact the school did have a deputy on campus that had a weapon, but additionally there were a lot of fail-safes built in to the school. Like all the classroom doors were locked, and the perpetrator actually wasn't able to enter the classrooms to deliver maximum carnage. And it's both sad to think that our schools have had to implement some of these safety tactics, but I'm also grateful that he was limited in the amount of carnage that he could deploy. I know certainly when I was going to school, now that I have a newborn and I'm thinking about this, every classroom was wide open. They didn't have self-locking doors or things along those lines. So those sorts of safety considerations are very important. Even the hurricane glass, he tried to shoot through the hurricane-rated glass in Florida to try and pepper the police officers as they were running through the lawn towards the building. But his AR-15 bullets were not penetrating that too, so that was incredibly lucky.
The doors that locked from the outside proved to be somewhat of a problem for some of the victims, because they were trying to escape, but they left the rooms, but they couldn't get back in. So once the shooter got to mostly the first and third floor, where people were still in the hallway, they couldn't get back into those rooms. So I think that demonstrates how important it is to educate students and faculty at these schools on how their fail-safes work. And when things like this happen, to hide in those rooms and don't be visible to the hallway. The survivors were the ones that stayed in the rooms and hid under desks or out of sight of the window, and he couldn't get into those rooms. So that's why they were able to survive.
That's a great point. So in an active shooter incident, you do not want to pull the fire alarm, because the fire alarm triggers evacuation. But if you evacuate from your safe harbor, you now become incredibly vulnerable.
I think just listening to the account of everything that happened on that day, there's a lot of people that did some things that they should really be commended for. People that were unarmed going in trying to help others, and Dr. Antebby for all the things that he did and all the steps that were taken to prepare for that. There were a lot of steps that they went through as an agency to prepare. I think that everybody in that community should really be commended, because it seems like it could have been much worse than what it was, fortunately.
Yeah, I hate to end the podcast on a sad note, but in fact, during his presentation, there was another active shooter incident in a Colorado school, and we're just starting to learn that there are multiple casualties and potential fatalities related to that. So certainly if you're a responder in that area or are affected from that in any way, shape, or form, our thoughts and prayers are with you guys. Wow, that's a really awkward place to end now.
Well, you forgot Ritu.
We can talk about Ritu.
Yes, let's of course, he always saves the day. None other than Dr. Ritu Sani, our medical director extraordinaire. So discussing some results that make you go, this was a very interesting format that he employed in regards to showing various graphs, figures, etc., but hiding all the x-axes and y-axes and asking the audience to guess what the study was looking at. So what were some of your takeaways on that?
Yeah, so he highlighted some pretty major pre-hospital studies that have been recently released, and one that has not yet been published that I was quite surprised by. He certainly talked about Paramedic 2 and how do we take the Paramedic 2 results and implement them, because now maybe we know that epinephrine isn't doing what we want it to do. Maybe it's improving ROSC, but we're certainly not improving neurological outcomes. So I think there's a big question there of what do we do with that data?
I think you had done a post too that is a new ACLS. Is that the 2020 algorithm? Is that a joke or is that real?
This was quite satirical.
Ah.
Yeah, it suggested bilateral intraocular EZIOs.
I see.
Which is not evidence-based, but trials are pending.
Yes.
I don't see what could go wrong.
I don't see what could go wrong, honestly.
Makes sense.
So more to come in regards to the ACLS algorithm, certainly, but continual work in progress as the evidence base develops, yeah. What are some other takeaways from Ritu's talk?
I think the big one that surprised me was unpublished data on tranexamic acid in intracranial hemorrhage, which showed, according to the graph that was shown by Ritu, increased survival when a 2-gram bolus of tranexamic acid was administered compared to, I believe it was half dose pre-hospital or placebo. Paper's not out yet. We can't really appraise it, but it certainly sounds interesting.
And there was a great podcast that they did, Mike Verkest did on it.
Oh, great. And I think we probably already know this, but lights and sirens is usually not indicated. Typically delivers more harm to the crew without conferring a disproportionate benefit to the patient. So it's certainly something to be conscientious of.
It's like honking in traffic. It makes you feel better, but it doesn't really help anything.
That's true.
I get to play with the noise, but it's not going to actually do any good.
Yeah, I feel like that's one we just got to keep hammering over and over. And that kind of plays to a pet peeve of mine, I guess, just the idea of response times as a quality metric for EMS. And I think I've just triggered Bex a little bit.
Oh, yeah.
There, but just moving past that a little bit, and we're here talking about evidence-based medicine, and I think as EMS evolves into a purely medical role as opposed to a transport role or a fee-for-transport model, I think then we really have to start looking at lights and sirens transport and say, where is the medical benefit of responding lights and sirens and transporting lights and sirens? I think it's a super important topic that we just got to keep hammering away at.
So you're saying we should view lights and sirens as a medical intervention?
Exactly. Absolutely.
Just like anything else that
now
can
it's a
cause
controlled
harm.
act.
Yeah, and I think that's an aspect of it that we talk about, but I think maybe the public doesn't talk about is what harm are we exposing patients to?
Yep.
And I think that's a real evolution is not only what benefit can we offer, but what is the potential harm and what harm are we exposing, not just EMS, but also the public too, by responding lights and sirens.
And I would say that there are still a large number of services that are transporting every patient with lights and sirens. And at this point with the data, there's no ground to stand on. It's really inappropriate. It would be like giving every patient ketamine that has no indication
wrong.
for
We
it.
don't do that?
I know.
What?
Nebulize it for everyone.
Yeah, believe it or not. So I think it's really time to evaluate our use of lights and sirens, and it should probably be less than 10% of transports, if not fewer, that are actually having lights and sirens. Because at this point, if you have a crash as a result of your lights and sirens use, you're certainly going to be liable, especially if you're not transporting someone that needed those lights and sirens.
It's an interesting metric, like we start to QA all our cardiac arrests, for example. So just QAing all the calls in which lights and sirens was used may be an effective way to start saying, okay, or educating that this may not be appropriate, start rethinking your standards and current practice. The medical benefit of lights and sirens may be questionable, but there certainly was an incredible medical benefit to attending this conference, and we were so excited to share some of the highlights of day 1 with you, and we're excited for day 2. So on that note, this is Rebecca Spratt, Michael Perlmutter, Andrew Merrilman, Mike Brown, and Faizan Arshad wishing everyone a safe tour.